Good evening, class. We're going to spend just a few minutes talking about things that I think it's important for you to review before taking the quiz number 2 for this class. And again, it's a lot of information we've gone through, and through quiz 1, and through the midterm. Now we're going to take quiz 2. So 1 and 2 kind of sandwiched around that midterm. And again, just some snippets of information, some concepts that I think you might want to review before you go in and take that quiz number 2. And if you remember back to Ara's article in that first module, there wasn't a lot of consistencies, not a lot of structure that occurred during, say, the 50s, early 60s when Ara generated that article. And one of the things that both HCFA, which was healthcare, financing administration, so it was mainly taking care of the Medicare Advantage or the Medicare population after Ara's article. So Medicare goes into effect in 1965, and so the government agency that managed that program in the late 60s, early 70s started coming together with the American Medical Association, American Hospital Association, to come up with medical billing codes, and they were implemented and used to ensure like consistency of treatment protocols, accuracy of reimbursement, accuracy of information and research, and especially accuracy and information of research, and the reimbursement piece of it is because as those codes were assigned and billed, then providers and the payers both knew exactly what you were going to be paid for that particular code. And in addition, it gave not only policymakers, but academics the opportunity to have accurate information that they could use in research, because prior to the implementation of the coding process, a lot of there was just not a lot of consistency, especially when it came to research. And when we start talking about, if you remember the videos talking about the billing practices, you've got things like on the institutional side. So you're talking about UB 92, talking about UB 04, talking about the CMS 1450. And when you talk to individuals in the healthcare arena, depending on which terms they talk about, when they're talking about institutional billing, you can tell how long they've been in the system, how long they've been in, functioning in that healthcare environment. I mean, I broke into the healthcare environment when we were still talking about the UB 92. I mean, that was the claim form, the uniform billing form that hospitals or institutions use to bill for healthcare goods and services. I think it was in 2007 that that UB 92 was kind of retired, and the UB 04 came into being, and especially on the electronic claims, because all of the government agencies and all of the payers were trying to incentivize providers to move to electronic billing. So the UB 04 was used for electronic billing. Then CMS came out with the 1450, which you could still use for paper submitted claims if you wanted to. So, and a lot of providers will bill both of them. They'll bill the UB 04 and they'll bill the CMS 1450. And then we talked about HCPC codes. And HCPC codes tend to confuse students in classes when we're talking about healthcare ethics, or we're talking about healthcare informatics or healthcare economics. And HCPC codes are Healthcare Common Procedure. It's a coding system. So Healthcare Common Procedure Coding System, HCPCS. And again, individuals in the business and in the healthcare environment will just talk about HCPC. We're going to do the HCPC codes. And level 1 HCPC codes are typically referred to as CPT codes. Clinical procedure, the CPT codes are level 1, and they tell you what the provider did. So a CPT code from the medium office visit is a 99213. And when anybody in the healthcare arena sees a 99213, they automatically know that was a medium level office visit falling in the evaluation and management series. And that was one that a healthcare provider, a non-institutional provider, more than likely was billing, especially if it came in on a CMS 1500, which is the claim form that healthcare providers use that are not institutions, that are not facilities. So basically, hospitals, facility, institutional type claims come in on that UB04 or the CMS 1450. Non-hospital, non-institutional claims are going to come in on that CMS 1500. And so that's the way you keep things segregated when it comes again to healthcare ethics, or we're talking about healthcare informatics. So, and on the HCPCS codes, remember when we talked about it, you've got a HCPCS code level 1, normally referred to in the business as a CPT code, and that tells you what the provider did. A HCPCS level 2 code tells you what the provider used: supplies, ambulance, transportation, durable medical equipment, crutches, wheelchairs, prosthetics and orthotics. All of those are going to be billed with the HCPCS level 2 type code. ICD-11 CM codes. So HCPCS level 1 tells you what the provider did. HCPCS level 2 tells you what the provider used. And an ICD-11 CM code tells you what the provider, why the provider did or used what they did. So CM code, so an ICD-11 CM code is for clinical modifications. An ICD-11 PCS code is for procedural coding system. So if you go into the hospital, let me think of something. If you go into the hospital for, let's say you're admitted for pneumonia, you're going to have on that claim form, on that UB04 form, you're going to have a lot of ICD-11 CM codes. Why the provider admitted you at the hospital, what they use, it's why you're in there. And that's going to be for pneumonia. Now, if you go in for, let's say you're going for a delivery and it ends up being a C-section, you're going to have some ICD-11 CM codes that's going to tell you why the individual, female, is admitted to the hospital for a birth or a delivery. And it's also going to have some PCS codes on there because there was a surgical procedure performed, because that's what happens in a cesarean delivery. So that's what you're going to see on that UB04 claim form. And when it comes down to the ICD-11 CM codes, it can provide, name and describe the disease. It can talk about comorbidities. It can talk about, what body parts affected. All of that information, and that's why it's referred to as clinical modifications. It's telling you the clinical information as to why a particular individual, and you'll see ICD-11 codes also on a CMS 1500. It's just the provider on a CMS 1500, the provider is not paid based on the ICD-11 codes. The provider is paid based on HCPCS level 1, which is a CPT code, or HCPCS level 2, which tells you what kind of supplies and things that the provider used. So that's what they're paid for, because most providers, non-institution providers, are paid based on a fee schedule. On a UB04, it's that combination of the ICD-11-CM and the ICD-11 PCS codes that drives the payment of that claim, especially if it's a DRG, diagnosis related grouper type code. It's a prospective payment system. And so you go into the hospital and services are provided, you're discharged, and then at that point, the hospital can take and play around with those ICD-11 codes to ensure that they maximize their revenue. Remember, self-interest, optimization, maximization of revenue on the provider side. And that's where, when you're talking about, healthcare ethics, that's where we're talking about DRG creep. 3M provides a software package that will take all of these diagnosis codes, both CM and PCS, and rearrange them in their order in such a way to maximize revenues. The hospitals are going to use that software package because they want to maximize revenues. Also, on a UB04, you have revenue codes. Revenue codes, again, we talked about, they're 4-character codes. They're total to a single line on that UB04 claim. And they usually show up in that field locator 42. Again, we talked about that, in one of the videos. And at that point, the revenue codes tell you where the service may have been provided, what type of service it was, what kind of supplies are used. So there are revenue codes for radiology, there are revenue codes for laboratory, there are revenue codes for emergency room. And so as you go into the hospital, let's say you go into the emergency room, you're going into the emergency room, and if you see that, if you see your claim that comes in from the hospital, you're going to have one line that has the revenue code for the emergency room. And if you had some blood work done, you'll have a revenue code line for the blood work that was performed. You'll have a revenue code if you had some kind of radiology work done. If you had some physical therapy done, there are going to be revenue code lines driven by revenue codes. Your revenue code shows up in FL42, form locator 42, or field locator 42. And you can take and crosswalk those revenue codes to information that find at CMS websites, you can find on the internet. All you have to do is type in revenue codes, and it will tell you exactly, where it was performed, what kind of service it was performed. I think it was in 1983, DRGs started to come into play because, especially, at that time it was HCFA, Healthcare Financing Administration. And Healthcare Financing Administration was in place from 1977 to 2001, I think. And in 2001, it became CMS. But they were struggling with, especially on the Medicare side, they were struggling with how to handle. So ERLA's 63 article, 65 Medicare came into play, and Medicare was struggling with how to reimburse for inpatient stays. And so in about 83, they came out with DRGs, prospective payment system, and they started with the DRGs because, at least when they came out, the theory was it was going to reduce length of stay in the hospital, it was going to reduce treatment costs, it was going to increase quality, because up until that time, hospitals were, either paid on bill charge or they were paid on a per diem rate. And so it was kind of a volume type basis. So the more bill charges the hospital generated, the more they got paid. And the more days you were in the hospital, the more the hospital got paid. But DRGs, because it was a prospective payment, the theory was it was going to reduce cost, reduce length of stay, improve quality. And unfortunately, over time, hospitals have gotten, and go back to the 3M software package, hospitals have gotten really good at taking and playing around with those diagnosis codes both the CM and the PCS, playing around with that diagnosis code information on a claim and what we call, again, DRG creep. So the higher level DRG you have, the more money you're going to get paid from the hospital side. So again, go back to your microeconomics and how we're trying to tie all of this together and how microeconomic theory impacts healthcare ethics. And this is an example of where you're seeing healthcare ethics being impacted. Again, we've talked about on the CMS 1500, so it's the provider, it's the medical provider claim billing form. They start playing around with the CPT codes. I think an example I used, if you bump it from a 99213 that's $60 to a 99214 that's $100 to a 99215, let's say it's $150, then you can see how providers are going to start playing around with those codes to generate additional revenues. Same thing with the hospitals. Theirs is called DRG creep as opposed to upcoding. And that DRG creep, they're trying to get that information on the claim to drive to a higher level DRG. And as they drive to a higher level DRG, the more money they can make, and the more revenue they can optimize. Let's see. An MDC, and we talked about an MDC. It's a major diagnostic category, and all of your DRGs are allocated at about 26 MDCs, and based on the information that is on the UB04 that shows up as a ICD-11 PCS code, so that implies a surgical procedure was performed. If the code's on there implies it's a surgical procedure, it bumps that into an DRG, into an MDC surgical procedure or an MDC medical procedure based on the ICD-11 PCS codes that are on that claim. We talked about the healthcare, and again, we'll go back to when I started in healthcare, it was a UB92. It went to a UB04, and now they've got a CMS 1500 out there. When I first started in healthcare, that was on the institution side. When I first started in healthcare on the physician side of the house, or the medical provider side of the house, everybody talked about the HCFA 1500. And now that, the Centers for, Medicare and Medicaid Services, CMS, now they've transitioned. And I don't remember the exact date, but somewhere along the way, I want to say I think it was in 2001. So HCFA was in place. That was the acronym that they used in place from 1977 to 2001. And in 2001, it moves to CMS. And so at that point, your HCFA 1500 moves to CMS 1500. But again, to me, it has always been a HCFA 1500, and I can't get away from that nomenclature. And that just tells you how long I've been in the healthcare industry. And again, the last thing just to remember when we're talking about HCPCS codes, level 1 HCPCS codes or CPT codes, depending on who you're talking to in the industry, tells you what the provider did. If it's a HCPCS level 2, and most people in the industry don't say level 2, they just say a HCPCS code. A HCPCS code is going to tell you what they use. So they're talking about medical devices, medical supplies, transportation services. And again, depends on who you're talking to in the industry. You can tell how long they've been in the industry, and you can also tell you start getting accustomed to the acronyms that everybody's using. But at the end of the day, when we're talking about healthcare ethics and the dilemma of healthcare ethics, it all comes back to coding, the claim form that the providers use, and is there evidence or information in the medical record that can back up the coding process or the information on those claim forms that a provider has sent in. If the provider sends in claim forms with certain billing codes on them, And a health plan can't take those medical records or medical charts and itemized bills and go back and track those codes back to the medical record and the itemized bill, then that's an issue. That's a reimbursement issue. Is it waste? Is it abuse? Is it fraud? And it's up to the individuals at the health plan and typically the payment integrity team. It's up to that group to determine whether it's waste, abuse, or fraud based on the information submitted by the provider on the either the UB04 or the HCFA 1500 or the CMS 1500, and trying to match that back to the medical record or the medical chart and the itemized bill. And with that, I think that should be all you need to do extremely well on quiz number 2. Next time we talk, we'll probably be talking about a review on the final. Talk to you soon. Thank you.